Bismillahirrahmanirrahim. We start this session on team approach for peripheral vascular disease. This is a hybrid session. There are about 22 people connected on Zoom. I hope they are able to listen us. Is the voice coming?
Yes, Zia, yes.
Yes.
Assalamu alaikum, Dr. Asna. So peripheral vascular disease is quite common, and it has multi dimensions. And one component is revascularization. Without that, wounds never heal, and patient end up in amputations. And the burden of disease is so much that we need a lot of manpower and lot of expertise. And one of the modalities is surgical intervention, and other is endovascular. Then beside that, we need medical therapy, and also we need reconstructive surgeries. We are very honored that we have Dr. Sohail Khan. Dr. Khan is graduate of AKU. He has his higher training in several institutes at United States in cardiology. He has been trained as a cardiologist and as an interventional cardiologist, and has been doing cardiovascular and peripheral intervention in US. He has experience in administrative work and develop vascular services in states, and is now the chief operating officer at NICVD, Karachi. So he is quite interested in doing peripheral intervention and helping the same objective which we aim to save the legs and the limbs of the patient. So I request Dr. Sohail to come and give a talk on team approach to deal this peripheral vascular disease. Thank you.
Put my phone on silent. Assalamu alaikum. Good morning, everyone. I'm very, very excited to be back in the hall where it all started back in 1998 when I came in as a med student. But I'm even more excited when I looked at the panel of experts, and I really appreciate what Dr. Zia did. It's a true multidisciplinary panel, which include foot and ankle surgeons, include diabetologists, medicine folks, of course, vascular surgeons. And then I was noticing I'm the only cardiologist in the hall, which is okay. So today I'll talk about the team approach to peripheral vascular disease. So when I was trying to prepare this talk, when I look at the panel of experts, it's such a multidisciplinary. So in this talk, I will not focus on all the tools and techniques of doing peripheral vascular intervention. So my goal is to give this broad talk, which will apply to all the folks who are in the audience as well as in the panel. And again, I want to simplify things as soon as possible, as much as possible. And again, my goal is also not to debate whether the endovascular is better than the surgical intervention. I think we've had these debates since 2012. And the one thing that we know now in 2022, that for most of PAD work, the endovascular intervention is the first line therapy. So again, we are not going there. So I have no financial disclosures. So I'm going to start off with this case. What I will do in this talk is peripheral vascular disease. That includes arterial disease, as well as the often ignored the venous disease. We'll talk about the arterial disease and we'll talk about the venous disease later. So this is the lady, 67 years old. She has a history of tobacco abuse. She had a very small right foot bunion removal, again, which is a very small surgery. That was back in December 2017. I used to be in Salt Lake City during that time. But a couple of weeks later, she, and again, if you look at her ABI, was 0.8. Again, we'll talk about the significance of ABI and how sometimes you cannot totally trust the ABI numbers. So she came in with this. So it all started with a small bunion removal and now this. And I've been doing it since 2012, and my primary referral in the US was mostly podiatrists and foot and ankle. So if you're a vascular surgeon, you have to be very good friends with them. So, I mean, the first, when they saw it, I mean, the first thing that they would think about is amputation. Well, Dr. Craig Walker that I trained with, that's his quote. For some reason, it is considered a conservative treatment to chop someone's leg off, an aggressive treatment, even to perform an angiogram. So we think angiogram is more invasive, but amputation, oh, well, that's a routine procedure. Just go ahead and chop the leg off. And this is based on the data. If you look at the Medicare data, about 50% of patients who undergo amputation, they don't even get vascular evaluation. And I see this more common in Pakistan. So this lady, we did the angiogram on her, and she had complete occlusion of the distal SFA and POP. And we did a drug-coated balloon angioplasty on her. And this is, she got 3-vessel runoff after the case. And the same patient, instead of sending her for amputation, she underwent aggressive wound care therapy, and she went on to heal this wound in a couple of weeks and months. So it's a fairly common disease, but the thing that is very disturbing is that nearly half of the individuals who have an amputation due to vascular disease will die within 5 years. And this is higher than 5-year mortality rate of breast cancer, colon cancer, and prostate cancer. Again, we don't talk about it very often, but the mortality is abysmal in these patients. And of person with diabetes who have lower extremity amputation of one leg, up to 55% of them will require amputation of the second leg within the next 2 to 3 years. So how do we define PAD? PAD is the presence of stenosis or occlusion of the aorta or arteries of the limbs. And it's one of the 3 cardinal manifestations of atherosclerosis in addition to CAD and cerebrovascular disease. Again, when we talk about PAD and amputation, these patients don't die of their leg amputation. They either die of heart disease or heart attacks, or they die of stroke. And it's pretty common disease. If you look at patients who are age more than 70, or if they have, or they're age more than 50, either with diabetes or smoking, their incidence can be as high as 30%. And even just age more than 65, incidence is about 20%. And of all the people who have PAD, very few of them are, symptomatic. Some of them are symptomatic, but minority of the symptomatic patients are getting treated. But look at this 10-year survival rate for patients with PAD. So even if the patients, if they don't have a symptom, if they have abnormal ABI, their risk of mortality is twice than those who have normal ABI, abnormal subjects. And if they have severe symptomatic PAD, you can look at the survival curve. It's abysmal. So why should we fear PAD if we are ankle specialists or primary care? I mean, it's just like cancer. It's slowly progressive, and most of the time it is asymptomatic. By the time you diagnose it, it's fairly late. Either they have heart attacks or they have amputations. So, and then it's the incidence increasing because of the increasing number of patients who have diabetes or they are getting older. So just like we do screening for cancer, why don't we do these type of aggressive screening for PAD work? If you look at the PAD severity, again, most of the patients are asymptomatic. Some of them are claudicants, but the focus that I'll be doing is on critical limb ischemia. Although it accounts for 1 to 2% of overall PAD patients who have either ischemic rest pain or tissue loss. But if we don't intervene on these patients, they are going to lose their legs. Again, I'm not going to talk about the intermittent claudicants, just critical limb ischemia. I mean, there's no question asked. If we don't intervene on these patients, they are going to lose their legs. And if you look at the survival in patients with critical limb ischemia at 2 years, alive with 2 limbs is 50%. Mortality is about 25%. So when you see these patients, when I see these patients in the clinic, when they come in with critical limb ischemia, my first question is always about their heart. Are you having any chest pain? Or if they have any atypical chest pain, again, remember, they don't die of their limb wounds, they die of heart diseases. So you should have a low threshold for asking these patients about those conditions. These patients need complete overhaul of their lifestyle. I mean, strict diabetes control, strict blood pressure control, ACE inhibitors should be used. I mean, even small things matter. Even if you're a vascular surgeon, foot and ankle specialist, if these patients, you should start them on either aspirin or Plavix, and you can reduce the cardiovascular event by 30% in these patients. Lipid statin therapy, I mean, not only improves their walking distance, it also decreases the risk of their amputation, also improves their overall survival. these patients be referred promptly to foot and ankle surgeon and podiatrist. Again, my number one referral in the US for 10 years were always podiatrists and foot and ankle specialists. So you need to work with them as a team. Always examine them with their foot, with their shoes and socks off. I mean, that is something we don't do very often. PAD, critical limb ischemia, usually their skin is thin, dry, shiny, hairless, the nail become brittle, hypertrophic, and rigid. And look at just feel for the temperature, the cooler extremities, and then they have this dependent rhubarb. If you look at the left leg, this is called dependent rhubarb. This is an ominous sign. This means patient has critical limb ischemia. You have to intervene as soon as possible. And if they present with ulcer, I mean, a lot of time just looking at the ulcer, you can identify whether this is arterial ulcer or venous ulcer. The arterial ulcer are usually punched out lesion, they're full thickness defect. They are usually present on the high pressure point, and they can be painful. They exhibit less bleeding. And compared to the venous ulcer that we will talk about later, which are usually larger, exudative, they're associated with edema or varicose vein, and they're painless for the most part. Let's move on to the screening or testing for critical limb ischemia. Like ABI is a fairly commonly used test. It's a great test to determine the presence of disease, doesn't require trained technician. Inexpensive. However, it is difficult to perform in the setting of limb wounds or ischemia. And if someone is older, diabetic, you can get a lot of calcification, and you can get above normal ABIs. ABI is recommended by ACC not only in patients who have suspected PAD, but even for risk stratification. For example, if someone is aged more than 65 or more than 50, and you're not sure whether you should start that patient on statins or not, I mean, ACC recommends doing ABI. But again, in our first case, when we said don't rest your head on ABI only. Why? Because calcification can cause false elevation in these patients. And ABI does not take into account the angiosome concept. It is basically looking at the vessel that you can feel or you can get pressures. But for example, just like in the heart, if we have the disease in the LAD, the anterior wall, RC is inferior wall, same in the leg. If you have anterior tibial artery, it supplies certain areas in the foot, and posterior tibial certain areas in the foot. So ABI does not take into account the angiosome concept. And what we need in revascularization, we need a straight line of blood flow all the way to the base of the ulcers. For example, in this case, the lesion is on the dorsum of the foot, right? And if you do the angiogram, I mean, if you do the ABI on this patient and you are feeling the posterior tibial artery, you may get normal ABI, but the problem is in the anterior tibial. So what this patient needs is, based on angiosome concept, you have to intervene on the anterior tibial artery all the way to the plantar arch. And that's what is needed for the wound healing in these patients. TBI is a better test than ABI because these small arterioles in the toes does not have calcification. The normal should be 0.7 to 0.8, and absolute toe pressure of more than 30 is favorable for wound healing. Segmental pressure, it demonstrates level of arterial disease, can identify disease even if ABI is normal. However, again, a critical limb ischemia patient is difficult to perform if someone has ischemic pain or the limb wounds. TCPO2, it's a great test. It gives us supplemental information about local tissue perfusion. A greater than 40 is favorable for wound healing. And I'm not sure whether you guys have this here at AQU or not, but this is something fairly commonly used in the US. Moving on to the imaging part, arterial ultrasound is the mainstay of non-invasive imaging. It can accurately assess the arterial anatomy. It also gives us hemodynamic information. Again, it's tech dependent, difficult to perform in someone with active ischemia, and it's also difficult to perform if someone has more of iliac lesion and if someone is very, very obese. CTA, it can accurately assess the arterial anatomy. It is associated with the contrast. If someone has abnormal kidney function, that can cause contrast-induced nephropathy. And also, if someone has a low cardiac output, or if someone is diabetic, it cannot really opacify below the knee vessels if there are a lot of calcifications. MRA is a better test than CTA. It also has some contrast-related issues. It is expensive. It is not available everywhere. Angiography, it can accurately assess the arterial anatomy. In addition to diagnosis, it also allows for immediate intervention. It is invasive. again, contrast-related issues, the cost issues. So again, not getting into that, CLI patients, you have to do intervention, whether it's endovascular or it's surgical. Again, endovascular is now is the first-line therapy, is the lower risk of perioperative morbidity or mortality, fairly good long-term patency data, especially with drug-eluting balloons and drug-eluting stents in the SFA and POP region. And if you look at all the greens here, this is for FEMPOP, this is for drug-coated balloons and drug-eluting stents. There's a limited role for atherectomy devices. And it's someone who is the end stage CLI where you don't have distal targets for bypass or you cannot cross with wire. This is the deep venous arterialization. It's fairly commonly used in the US nowadays. So again, let's go on to the case. 82 years old, history of hypertension, CKD, diabetes, a non-healing ulcer, first and fourth toe, painful ulcer. Again, just on the physical examination, you could see, again, physical examination history is very, very important, in these patients. Again, just like in a first kid, it always starts with a small bunion removal or small ulcer, but this patient had resting pain. So because of abnormal kidney function, we did a CO2 angiogram. Dr. Zia, do you guys do CO2 angiogram here on these patients?
Yeah, it's a good modality, but we are not offering it.
Okay. It's very inexpensive, very easy to use, especially if someone has abnormal kidney. This is something, again, very safe. So we can definitely talk about it. So this is a CO2 angiogram. And as you can see in the distal SFA, there was complete occlusion. So you can see a lot of bridging collaterals. So I tried to wire it from above. The wire kept going into the collateral. So what I did was, as you can see here, we went pedal, put a pedal sheet, and then we went backwards and we crossed the lesion and we snared the wire from above. And again, did a endovascular intervention on this patient. And right on the table, you can see the color coming back in these patients. So again, the point I'm trying to emphasize is history, physical, as well as if someone has abnormal kidney function, it's not a contraindication to do this procedure. Now we can use carbon dioxide in these patients. This was another patient. Actually, this was my first month after I started my first job. 58 years old lady, hypertension. And again, for you guys who are in a multidisciplinary hospital like AQU, you should be aware of this. She underwent total knee arthroplasty 2014, and a couple of weeks later, she came in with severe pain, numbness, as well as these ulcers. Just looking at these ulcers, you can see, again, this is arterial ulcer, right? Exhibit less bleeding, punch out lesion, very painful. And this was the skin perfusion test, which was severely abnormal in the right leg compared to the left leg. So again, I didn't want to, waste time, not waste time, but, you should always do the ABI and all that stuff first. But, just based on the history, I knew what's going on. So you can see the new knee joint here, and but very poor flow down there. So what's going on? So did the lateral shot, and as you can see, there's complete occlusion of the popliteal artery behind the new implant. So this is what you see on the right lateral shot, complete occlusion. So this was most likely trauma during the knee surgery. Again, 100% of these cases go into the lawsuits. You guys should be aware of that. So again, we tried to do the endovascular first, could not cross it from above because we could not really see the cap. We went from the foot and backward. I did not want to put a stent at that time. There was not good, Supera stent available. We just did the balloon angioplasty, but I told my vascular surgeon that this may reocclude because of the trauma. So just be ready for it. So we opened the vessel. As you can see now, the flow is back there. But then 2 hours later, there was reocclusion, and our surgeon saw the patient. Again, it was a multidisciplinary approach, and she underwent she underwent bypass, and this is the skin perfusion test after 2 weeks, which almost came back to normal. So individuals with PAD have exceptionally elevated risk of cardiovascular events. The general practitioner, PCPs, podiatrists, diabetologists, they must all be engaged in the diagnosis and management of PAD. Yeah, it can be life-saving. Again, it's not about just the leg, it's about the heart. Always remember it's about the heart. They need to be on antiplatelet, they need to be on statin, they need to be on good blood pressure therapy. They need complete overhaul of their lifestyle. So that was arterial. So let's talk about the venous. It's a often ignored child, and I will try to convince you that we should not ignore this anymore. No one taught us about venous disease in our 3 years of medicine, 3 years of cardiology, 1 year of interventional cardiology. And this is something that I started learning about during my practice. This is a bold statement. We often think of venous disease as a cosmetic disorder, right? Arterial Ulcer, reticular veins, varicose vein, we send them amputation. But this is not just a cosmetic disorder. Again, bold statement, this is the most prevalent, most ignored, and most misdiagnosed condition. And if you look at the prevalence of this disease, it's more common than Alzheimer's, stroke, cancer, coronary artery disease, all combined. And about over 30 million Americans are affected, but only 1.9 million of them seek treatment, and the vast majority of them remains undiagnosed or untreated. And how they present, they usually present with edema. And we think that this is because of the heart. We start them on what? We start them on diuretics. Or if they present with lower extremity pruritus or neuropathy, we start them on different sorts of pain medications and cream. Or if they have restless leg syndrome, again, very expensive medication. Or if they present with ulcers, we keep on treating them without looking at the underlying condition. And these venous ulcers compared to arterial ulcers are very hard to treat. If you have a foot and ankle surgeon, they can definitely attest to it. And if you look at the poor healing, a lot of costs associated with it. So the underlying cause of chronic venous insufficiency, as you guys know, is the abnormal valves inside the vein, the deep veins and the superficial veins. And these valves allow the venous deoxygenated toxic blood to move in one direction, which is up. And if these valves are leaking, the blood tends to seep back into the legs and cause all those symptoms. And most of the time, the venous reflux is in the superficial vein, but then you can have it both in the superficial as well as deep veins. And then not only it's because of the abnormal valves, it could also be compression above around the iliac veins, and that could be due to underlying malignancies or fibrosis, or May-Turner syndromes, or they can be popliteal venous entrapment. So there are other causes that we again tend to ignore. So what this leads to, it can lead to varicose vein, and slowly, gradually can lead to edema, skin changes, increased risk of ulcer, and this is the final common pathway. They end up having venous ulcer, which again, as I said, is very hard to treat. On examination, they can present with small, cosmetic blemishes like reticular vein telangiectasias or malleolar flare or bag of worms like this, or edema. I mean, again, don't underestimate edema. In some patients, it can be quite painful. It can limit their activities of life. And if we have ladies here, they cannot wear their shoes that they like. I mean, that can also be a big lifestyle change. So edema is not, benign that we think. On physical examination, they can have a more like advanced stage. They can have hyperpigmentation, lipodermosclerosis, which is again more advanced, atrophy blanche, and finally ulcers, which are usually, as I said, are full thickness associated with edema, less painful. So what the Society of Vascular Surgery recommend when you see this patient, it's always good to document their SEEP classification so that, we can talk to each other. We understand at what stage the patient is. And what SEEP stands for from C0 to C6. C6 is if someone has active ulceration. C5 is if someone has a previous healed ulcer. C4 is patient with skin changes or lipodermatosclerosis. C3 is edema. C2 is large varicose vein. So when you see this patient, you have to look at the clinical etiology, anatomy, pathophysiology. So when I document, okay, this patient came in with skin hyperpigmentation, I write in my notes C4. Now there's C4A, C4B, but C4 means that they have venous disease with hyperpigmentation. And if that patient goes to Dr. Zia, he will understand at what stage. Or if I intervene, is there any difference, or have you made any changes in this patient clinical state? So the first line therapy, this is the most commonly used. We recommend, exercise, weight loss, leg elevation. Compression stocking is again, we'll talk about it. It's very recommended, but does it really work? That's questionable. And putting compression stocking 20 to 30 millimeter of mercury on a patient, elderly patient like this is not easy. And just a highly overrated form of treatment, miserable result on an intent to treat basis and compliance. The endo, once we diagnose whether someone has venous reflux, we can also recommend closure of those veins. There are two different modalities. We can recommend thermal tymosine ablation or non-thermal non-tymosine ablation. I'm not going to go into detail of that. So basically, you put a catheter into the vein, either by using chemicals or laser or RF ablation. You can shut down those superficial veins. Again, we don't close the deep veins, right? But I will give it a little twist. And again, I'm trained as a cardiologist, so I always have to go by guidelines. So that's what we were taught. So I'm going to look at the guidelines, not cardiology guidelines, but let's look at the vascular surgery guidelines. What do they say about management of venous leg ulcers? So they give different grades to different recommendation. Grade 1A, B, C. Again, strong recommendation. Grade 2 is weak recommendation, right? So strong recommendation, weak recommendation. So let's look at what do the guidelines say? Okay. So, I mean, we do vein ablation all the time, right? This is the most common modality. Even in the US, if you see a vascular surgeon or emergency room physician or a primary care physician, when they're about to get to their retirement stage, what they do is that they start venous clinics. And what they do in venous clinics, vein ablation. It's very easy to do. It's highly reimbursed, right? But if you look at if someone has ulcer and how much it helps in ulcer healing, the grade of recommendation is 2C. Not only weak recommendation, but not A or B, is C, weak recommendation, right? Ablation prevention recurrence. Yes, there's a good, recommendation that when you do ablation, it might prevent. But when it comes to healing, the recommendation is 2C, but we still use it and it works, right? But look at this last one, 1C, which is venous angioplasty and stent recanalization. Is grade 1 recommendation. How often we use it? It's very rare. Again, this is not American College of Cardiology guideline. This is vascular surgery guideline, right? Why do we say that? On what base these? So in the past, we usually use Vinography to see whether someone has venous compression or not. But someone who does endovascular, I mean, the angiogram works great in the arterial disease, and the venous disease is not as reliable. So with the advent of intravascular ultrasound, what we have found is that those patients who had venous ulcer or C4, C5 disease, those who have had reflux, and when we looked at the IVUS, we were surprised that majority of them have combination of obstruction and reflux. Obstruction means more above the inguinal ligament. For example, we tend to ignore a lot of May-Turner syndrome, especially when they present with unilateral leg pain or DVTs. Now, May-Turner syndrome, like if we have 100 people sitting here, I mean, 25% may have May-Turner anatomy, which is compression of the left iliac vein by the right iliac artery. But syndrome is not as common. May-Turner anatomy is common, but May-Turner syndrome may not be as common, but that usually we tend to ignore this. For example, in this patient, when you do the venography, you may not see the compression here, but if you do the IVUS, you can see this beautiful pancaking here by the artery. So this is how the May-Turner looks like on IVUS, and this is post, stenting. Or if you see a patient who says, okay, I had DVT about 20 years ago. I mean, you all know if someone has a massive DVT, large clot burden, the heparin or anticoagulation does not dissolve the existing clot. It only prevents further propagation of the clot. What dissolves the existing clot? Your own TPA, if you give them thrombolytics, or if you do the thrombectomy, right? But if it is a large clot burden, and after a couple of years, these patients present with complete obstruction of those veins, especially proximal veins, because of perivenous fibrosis, right? So this is something we tend to ignore. And these patients, they come in with cellulitis, and we think this is skin infection, but we don't look at the underlying cause, which could be venous disease or obstruction. Or patient with lymphedema. I mean, this is something that we are finding out. Many of these patients have underlying venous disease that we need to look at. They may have severe iliac vein stenosis. Or again, this patient lymphedema. I mean, this patient ended up having complete occlusion of the left iliac vein. This is post-intervention. And this is lymph study on the same patient before intervention and after intervention. You have seen the improvement even in their lymphatic flow. Or IVC filter. Nowadays in the US, we have to be very, very careful not to put IVC filter on every walking patient, because this is what we see after 15, 20 years down the line. We find out that yes, they had IVC filter, patient forgot about it, but when then you evaluate them, they may have complete obstruction of the IVC now. So there is nothing else we can do. So who are the patient that we should evaluate for iliac vein obstruction? In addition to the superficial venous reflux, which is very easy to do. Again, if someone presents with venous ulcers, right? I mean, or C4 and 5, not every edema case, unless it is severe edema, which is out of proportion to the ultrasound findings. Or if someone has DVT in the past, as I said, even these patients may present with complete obstruction of the veins 10, 15, 20 years down the line. Or if someone had previous pelvic surgery, radiation, or trauma. Or if you get a patient who had multiple vein ablation in the past and still presenting with the same symptom, you have to rule out obstruction in these patients. There are different ways of diagnosing venous stenosis, but I don't want to go into that. But the non-invasive testing there's a lot of, it's very operator dependent, especially in the venous disease. Patient, for example, venous ultrasound depends on patient size, bowel gas, and depth of penetration, patient comfort. Again, there's a huge inter-operator variability. The venous phase contrast CT also need to work out a protocol with local imaging center, radiation dose and contrast reaction. Reading radiologist interpretation, a lot of time, like for example, I was in Salt Lake City 2 years ago, 40 years old, unilateral severe edema, venous reflux study normal. I mean, these patients, you may even get normal venous reflux study. Send him for a venous phase CT, and the radiologist called me that everything is normal. But when I explain the condition, what's going on, and look for any obstruction or May Turner, and hold and behold, he called me 30 minutes later. It's like, yeah, you are right. I can see the venous obstruction on this patient. So again, it all depends on who's reading it. The same goes for venous MRI. But again, if we are sitting in 2022, the gold standard for venous disease, for venous obstruction is intravascular ultrasound. It literally takes 10 to 15 minutes to put the catheter in and do a quick run, and you can diagnose a lot of venous condition. Venography, the same story, is a poor diagnostic sensitivity. Venogram has been considered normal about 25% of the limbs, where IVUS showed more than 50% narrowing. Again, IVUS nowadays is a gold standard in diagnosing venous obstruction or venous stenosis. Why? It allows for to assess true extent of the disease, allows for intraliminal evaluation of the disease, precise stent sizing, which is extremely important in venous disease because they tend to stretch, and you have to be very careful. Otherwise, your stent may go upstairs in the heart. So IVUS helps with that, and then it can also diagnose trabeculum and perivenous fibrosis that you don't tend to see on venography. Again, like in this patient, severe perivenous fibrosis that you don't see in venography. This is Dr. Raju is one of the pioneers in venous disease. I mean, even if you have patients who have both venous reflux as well as obstruction, a lot of time when you fix the venous obstruction, these patients tend to do a lot better in terms of symptoms. Again, the patency in the stents is far better than arterial disease. For example, if you have a non-thrombotic obstruction like May Turner syndrome, the patency even at 3 years is more than 90%. And if it is post-thrombotic, it's maybe about 70, 75%. And the venous surgical disease is very messy. And if you talk to a vascular surgeon, I mean, its patency is not great. So now we have options. And again, this is going through the algorithm based on SVS. When you see a venous ulcer, or if you see C4 and above, always look for both obstruction and the reflux. If you have complete obstruction and you end up burning the superficial vein, you may do more harm to your patient than benefit, right? So that could be their conduit. So always look for the obstruction. And now when I started this back in 2014 and 15 is we did not have any FDA approved stent. I used to do a lot of wall stent. Now we have Boston, had approved stent, which was called back, but Vinovo is barred, makes a stent. Medtronic every stent also got recently approved by FDA. So now we have 3 or 4 FDA approved stent for this condition. So, I mean, this is now like one of those common procedures in the US now. So venous obstruction is underdetected and underestimated. You must have a high clinical suspicion and utilize all available invasive, non-invasive techniques for evaluation based on patient's presentation. When a patient with appropriate SEEP score presents, just don't only think of reflex, also think about obstruction. You'll be surprised, it's very common. So let's talk about some more cases. This was in 93 years old. Again, that was in Utah. So if you know about Utah, it's Salt Lake City. I practiced there for 5 years because I love the mountains and the skiing, and people are very active over there. So 93 years old is not like 93 years old in New Orleans or in Pakistan. They're fairly active there. He used to hike every day. So this guy had a previous follicular lymphoma, which was treated, but he presented with this unilateral severe leg pain and edema, and he could not play golf anymore or hike anymore, and multiple ultrasound, negative for DVT, negative for negative for reflux, and of course he had an echo. They think it's heart failure. So as you can see, the right leg is bigger than the left. I mean, once we did all the testing, again, he was of course started on LASIK. That's what we think about edema. It's either the heart or the kidney, but it's more than that. So did the Vinography. You can see some obstruction here. Again, yeah, but what else is going on? So we did the IVUS. As you can see here, complete occlusion of the vein. So what are these? Can anyone comment right here? What is compressing these veins? So this patient has previous history of follicular lymphoma, right? Yes, lymph node in the pelvis compressing the veins on both sides. So anyways, so we did intervention on this patient, and the same patient without any, LASIKs, and a month later, pain is gone, and now you can see that both legs looks the same size, right? Again, how often we ignore it. And this patient, once you have that obstruction, is also at the risk of DVTs, right? So need to look into it. This is another 50 years old male with a history of recurrent DVTs. Again, when you think about recurrent DVTs, always think about obstruction somewhere. He has SEEP class 4, severe leg pain and edema that was affecting his quality of life. He was going to this outpatient vein center, multiple vein ablation, perforator. Again, it's a 5-minute procedure, gets paid really well. But no one is looking at the underlying cause. So of course, we did the venogram on the right side. You see the complete occlusion of the iliac vein right here. You see that's the venogram. But on the left side, 100% gone. These are all the collaterals. You see this here? And this is the post-intervention. We put the stent in both iliac veins. It's a remarkable improvement in his symptoms. 50 years old, I mean, it's they can have pretty bad quality of life. Again, once we put the vein in, those collaterals that you could actually see it on his skin and the groin were gone right after the stenting. Again, 63 years old, car salesperson, he depends on his leg. He has to stand on his leg for 8 hours, 10 hours. Now history of, again, DVTs, venous reflex in both superficial and deep veins. But again, before we went on to do the ablations and go that route, let's see what's going on above. And as you can see, complete obstruction of his iliac vein, the collaterals going from left to right. Again, when you just do the venous reflux or ablation, you may cause this patient more harm than benefit without fixing the obstruction. So I can go on. This is severe edema, another lady, previous DVT, both reflux in the superficial and deep veins, obstruction. This is the IVUS, complete occlusion of the veins here. This is post-intervention. This is the beauty of IVUS. You can actually use it for sizing. And this is another patient, 63 years old. She was my office manager. Again, severe pain affecting. She had large varicose vein. But venous reflux study was, just mild reflux, but if you look at the symptoms and you talk to her, the other symptom in addition to her legs were also, she had this chronic pelvic pain, right? She had painful sexual intercourse, dysuria, heaviness in the legs. And if you go to any OBGYN clinic, 30% of their patient would be that, right? And we either offer them hysterectomy. If you don't find anything, we either offer them hysterectomy or like, yaar, ye to pain ki wo shikayat karti hai, maybe she's depressed, antidepressant pe daal dete hain. But the chronic pelvic syndrome, pelvic congestion syndrome is something that we don't talk about very often, especially if it is associated with varicose vein and leg pain. They might be having some venous reflux in their ovarian vein. So anyways, so these were her legs. We found some obstruction in the vein, as you can see. We fixed them, but more importantly, while at it, I also did the venogram of the left renal vein. Again, the left ovarian vein drains into the left renal vein. The right ovarian vein drains into the IVC. So you should not see these reflex. So now the blood should be flowing toward the IVC, but look at it, the blood is going all the way into the pelvic vein, back into the IVC. So this is severe reflux in the ovarian vein, and this is what was causing her symptoms, which is, chronic heaviness, pain, and so we also did in addition to fixing the iliac vein, we also did the coil embolization after ruling out the nutcracker syndrome. I don't know if any resident would talk about it, but you should also rule that out in these patients. So we did the coil embolization without doing any, venous ablation. The same patient, after a couple of weeks, pain is better, pelvic pain is gone, her quality of life is improved. Again, the things that we do in medicine is two things. Either we want to save lives or we want to improve quality of life, which is very, very important. So amputation prevention is a team sport. Not one specialty alone can save the legs. Any wound should warrant vascular evaluation consultation. And if you live in a medical legal society like US, lack of vascular workup in active wounds can be a medical legal liability. When assessing vascular workup, think both arteries and veins. Again, we tend to ignore veins, right? And so it's a team sport. It takes a village to treat this condition. Again, I'm very glad that we have such a multidisciplinary audience today, and this is something that we need to build on. We need to keep doing. So thank you very much.
Thank you, Dr. Suhail. If there's any question and comments, they are most welcome. I see you are very enthusiastic for the treating venous disease. That is great, because this is often a neglected disease, and the message which you have conveyed is very rightly that there is, beside reflux, there is going to be obstruction and proximal in a non-healing wound, which is often ignored, and the stenting is the way to treat it off, which is non-invasive. That is great. But the most important aspect for which I see the other neglected part is the arterial insufficiency, which we see in our diabetic patients. And there is increasing awareness, and I am very happy that all specialties are working on that to save the limbs. So I just start my discussion. We are very fortunate that we have Dr. Ziad Sufi, Dr. Kamal Yusuf. Dr. Ziad, can you comment how prevalent is peripheral vascular disease, and what is the referral system in our setup? Are the patient presenting earlier or late in our setup? And what is the amputation rate? Is it really preventable or not? Yeah.
Well, the association of peripheral vascular disease and coronary and carotid disease was, I think, first shown by Hertz up in clinic. He angiogram all patients coming in with peripheral vascular disease and find out the percentage of involvement of cardiac and carotid. So this was way back in the 70s, in the early. So this has been known for a long time, except that people have not been. Multidisciplinary approach is very important. You should be aware of the preconditions which lead to this, and they should be evaluated and treated first. So you need somebody who evaluates the patient well in the beginning, whether it's a peripheral vascular surgeon, whether it's a cardiologist, whether it's a dermatologist, and all the field of vascular medicine just come up, and then they should approach the appropriate people, and treatment should take place at a much bigger disciplinary. So, good thing now is that awareness in Karachi is more. Even the local GPs are sending patients for ultrasound, at least sending their cases sending off.
Yeah.
So at least we're picking up a lot of things there.
Yeah.
Arterial disease is something which the catheter using physicians are very enthusiastic about. They'll see a lesion and they want to dilate it, but please remember the patient has to be taken individually. All lesions do not to be antiplastic. You have to look at the whole patient and the benefit that you will give to the patient with that. So a physician taking care, like vascular medicine, I think should be enough coming from which is very important. The other thing is venous disease grossly ignored, even in the West, only now in the past maybe 15 years, 20 years, and then endovascular being very problem there. And I choose endovascular ultrasound. I think we should look into it very seriously now. With this thing. And I do think it's very difficult to perform and ask the radiology colleagues to be help us with that.
We want to listen.
So awareness is there. I think we need to educate the GPs more and physicians more. And
Yeah, Dr. Kamal Masood is with us. Sir, can you make what is the pattern of patient you are getting for peripheral vascular disease? When you try to refer, or the patient have awareness for that, and how is their non-invasive modality quite effective in detecting those issues? So what are the challenges you find that patients with diabetics have peripheral vascular disease when they are presenting? Are they presenting late? And what are the problems you find in actually detecting disease and referring it?
Yeah. I mean, it's a mixed disease. So what we see, I mean, neuropathy is there as well, and perhaps something which is, as you said, neglected. We do in our diabetes form, we have a foot examination portion there, and we always palpate the dorsal sphincters and the posterior tibia. And intermittent claudication in the West is very common. If we take the history, here we won't find that much, but perhaps the at AKU, the patients that we are seeing, we are not seeing as many complications maybe as other centers in Karachi, where optimal care is not being provided or the patients work. But it's a significant disease, and treating all the risk factors are there. In inpatients, always we see patients with our vascular colleagues and following those patients and modifying their risk factors, diabetes control, lipid control, blood pressure control, all are important. We do Dopplers a little bit. ABI is time consuming in a busy diabetes clinic, not in all patients, but we just put the Doppler over there most of the time. If we don't feel a very good pulse over there, identify those patients. Seeing critical limb ischemia, dependent Buber, other things, it's relatively less common as I expected, perhaps in our setup that we are doing. Maybe outside, if we go to other areas of the town, the complications may be higher.
Yeah, that is the. We have Dr. Kamal Yusuf. He has developed a model which is actually multidisciplinary. He gets patients with peripheral vascular disease. He is working with interventional radiology, and we with very good results. So I want to listen. What is the pattern of disease outside AKU, and what is your model of actually offering them intervention and saving the limbs?
Right. Just to say that this is my 23rd year practice in Karachi. And initially I came as a vascular surgeon. Then gradually I started knowing that this is not the answer because the things are changing very rapidly. So from 2004, I started going into the different intervention meetings and gradually learning the techniques. And started applying gradually. And now we are at a stage that we can compare our surgical results and the vascular results. As far as the endovascular results are concerned, we started around 10 years back. Now we have got 275 cases of peripheral vascular in one center and around 75 in another center. And we are doing the infrapopliteal angioplasties, and I found all this difficult to do the infrapopliteal bypass grafts because the area was quite badly infected, and the patient was needed sepsis, and the thrombosis was quite common, and the infection was common. Then we started working with the angioplasties, and gradually we learned the techniques, and we can go up to the pedal arches, and we are going up to that level. And my results, our result is so far extremely good in saving the things. As far as I can say that is more than 75% of patients are coming to us with minor those applications. As far as the SFAs and other diseases are concerned, we in vinyl we are not using any stents. Neither we are using the angioplasty that is because we cannot afford to do that. So we need a simple balloon angioplasty and people and get very good results. And we are taking most patients in the follow-up on 3 months, 6 months, and on a yearly basis, keeping on them 3 regimes, hospital support, exercise, for ILX, we are, for the ILX, obviously, you need to open the abdomen and go for the bypasses. But we have adopted the stents in the ILX we have a good number of cases, including the kissing stents and the individual stents. We have done the paroxysmal quite a lot. But peripheral work has definitely changed in my practice. Patients are coming, we are getting them, we are working on them, and then we are taking them to I hope because the audience is coming,
yeah, that is great.
Surgeons are coming and people are getting more aware. I'm quite sure that with the time it will
Improve.
and improve.
Yeah. For the wound, do you have the help of plastic surgeons and the foot and ankle surgeon? Dr. Tashveen is with us. Any comments how you deal with the foot and ankle deformities and help achieve our goal, the limb salvage?
Doctor. Yes, thank you very much. Brilliant talk, Professor. Indeed, these peripheral vascular problems are something which we as orthopedic surgeons see quite frequently. Patients with chronic ulcers, non-bleeding wounds, problems after surgery in terms of bone union, in terms of skin bone union. So we do keep a referring patients to vascular surgery, but quite often it is late. Before the procedure, if it is recognized and addressed, that would obviously be a much better outcome. From the orthopedic perspective, I think one of the things which is also missed apart from the vascular insufficiency, venous and arterial, is the presence of bony deformity, which tend to cause problems with the skin. So chronic ulcers sometimes have an underlying bony deformity which needs to be corrected, or sometimes patients have neuropathic ulcers which has resulted in a Charcot foot or a Charcot joint pathology. Diabetic feet, for example. I've seen children with the congenital neuropathic disorders whose wounds did not heal, and for years. And once you corrected the bony deformity, within 2 weeks you see complete healing of the skin. So those kind of things keep happening, and diabetic feet especially, they are very prone to deformity. And the multidisciplinary approach which you talk about is absolutely essential. Getting a vascular surgery and vascular interventions, plus nutrition management, plus appropriate orthotics, plus any correction of any bony deformities there. All of that is required to really get your
Just one point I want to emphasize is that it's not black and white arterial ulcer venous. You can also have ulcer with mixed etiology, both arterial and venous, and you can have some diabetic neuropathy. And if I'm an orthopedic surgeon, if I have a patient more than age 40 with certain risk factors, even for knee joint replacement, foot and ankle, I would always like to do either ABI or some vascular ultrasound evaluation before you take that patient to the OR. Again, it's very hard to manage the complication after, but it's good to know before your vasculature, before you do any intervention.
Yeah, so we have a short of time, but we want to listen the comments. And we have some questions also. The question, we have three models of actually revascularization. One model is done in the PIR that Dr. Azim is following. One model is actually in OR, which Dr. Azim and Dr. Farid is following. One model is by Dr. Fahad, which he is developing his setup and using cath lab. There are challenges, there's need of collaboration, there is challenges in the equipment and in actually workflow. So I would like to listen the comments of you, what are the challenges you are finding and what is the referral problem you are getting and how you are dealing with that. We have a question, we want to ask a question before I go there.
Thank you, Dr. Sayed. This is Prabhat, Chief President Cardiology, and pleasure to have you here, sir. My question is that you have a typical South Asian uncontrolled diabetes coming to your clinic with stable chest pain and symptomatic peripheral arterial disease. As a cardiologist, your first insight would be to keep the patient on optimal guideline-directed medical therapy for symptomatic, as he's symptomatic for chest pain. What is the role of medical therapy for symptomatic peripheral arterial disease? A. B. Now that the patient is on medical therapy, just like we assess ischemia in patients with stable chest pain with intermediate probability of adverse cardiovascular events, is there any role of stress testing for patients who don't have resting peripheral arterial disease symptoms? So is there anything up with the stress testing of the peripheral arterial disease?
Again, it all depends on the symptoms. When I said initially the intermittent claudicants, and if you look at the Society of Vascular Surgery, even ACC guidelines, you can, in addition to the aspirin, statins, and blood pressure management, you can use, silastazole in those patients. But again, if you look at the study, yeah, you may improve their walking distance to 10 to 15 feet, But I tend to be not very aggressive with intermittent claudicants unless they have really activity limiting claudication. They cannot carry on their activities of life despite on silastazole, despite on all the other medications. Now, again, the chest pain is the same story with with ischemia trial and everything. If you look at my practice in the last couple of years, I've been shying away from doing a lot of cardiac stress testing, right? It's well documented if someone has stable angina, good medical therapy, now they're feeling better, doing PCI is not gonna make a huge difference in their life. So again, it depends on both symptoms, right? So yeah, if someone has had resting pain, unstable angina, of course, you wanna do something about it. And if they have a high risk factors, I would just do angiography of the heart. And the legs, we can wait unless they have resting pain, they have wounds, which is again, different story. So you have to look at the whole patient, it's very complicated question. Okay.
Life comes before limb. So we vascular surgeons say life comes before limb. And when we treat the limb, it actually saves the life. So we have Dr. Nanik, we will listen about medical therapy and what are the guidelines for that. So I start from Dr. Azim. What are the challenges you are finding in the inventory and the care of those patients?
Yeah, first of all, I would like to appreciate Dr. Swell for your excellent presentation. But the ground reality in Pakistan are bit different. Unfortunately, the agility and the concept of doing the teamwork is increasing, and this will inshallah lead to better patient care. Dr. Wamisu has set an excellent example in the city where he is having collaborative approach and he is doing a lot. One of the disadvantages of doing in Seattle and everyone treating their own patients that the inventory never builds up. And we, the vendors, they are not keen to bring out stuff which is easily available overseas. Here the vendors are also struggling with the market dollar value and everything else, that they are not keen to bring even in the normal wall stent. Sometimes it's very difficult to get a simple wall stent or simple balloon rather than the balloon or the dilated stent. So we are struggling, but inshallah we'll.
So I see Dr. Fahad, he has done tremendous work in actually salvaging the limbs and develop a center and striving for that. I definitely want to listen what are the challenges and what are the goals he has working for.
Thank you, Dr. Sharif, for this excellent presentation. I am working at Trauma Center, Venous as the head of vascular surgery. Well, I think the basic problem that we face is that patients present with us at a very late and advanced stage. So that increases our workload significantly, and the output is, of course, not what one way. So, plus the other challenge that we face is, as I mentioned, is the availability of inventory. Building a teamwork is definitely very important, and increasing physician awareness, involving different modalities. We've started things, and inshallah, I think things will improve. A lot of other centers have started this as well, and our and our AQ team is also leading the way forward. So inshallah, working as a team, I think things will be better.
At AKU, we actually are very blessed that we have very cooperative dietitians, and also we have very good radiologists, and our vascular surgeons are quite, their mind is quite set in a philosophy of the limb surgery. Dr. Nadeem and Dr. Fried are doing excellent work in actually doing peripheral intervention and offering them in the OR. Any thoughts? What are the challenges you find in doing OR work, and what are the type of the patient you are finding?
So again, it's a tough question. I was the high volume operator in the US for many years, but the ground realities in Pakistan and then at a public hospital are very challenging. It doesn't matter what you have done in the US. जब आप यहाँ पे आते हैं तो आप जो पीछे line में खड़े हो जाएं तो and the other thing that I want to emphasize is that it's a cardiovascular institute. Of course, we have more cardiologists. And one of the thing, again, being a cardiologist, I would say it loudly, one of the problem with a lot of interventional cardiologists is that they want to do everything. They want to do stroke, they want to do PAD work, they want to do structural heart disease, they want to do coronary work. You cannot do everything. You know, you have to pick and choose. I chose coronary and peripheral. That's it, you know, for the last many years. I mean, later on, I got into some structural part too. But the good thing is that being a cardiology center, one of the largest, I would say, one of the largest cardiac network in the world. They have 10 satellite centers. I mean, they do 40 heart attacks every day, just NICUD Karachi, forget about Sukkar. So we had that access to the catheters and the wire. A lot of time you can use the same coronary wires and catheters in the periphery as well. And then it's a tedious work. PAD endovascular compared to the coronary. So you have to have that passion and enthusiastic. And we have one or two people who really want to do things. And the other thing that we have done is that we have Dr. Irfan Lutfi, who was interventional radiologist, and he has started this stroke program. So in a cardiology center, we're also doing stroke program led by IR with a team of other cardiologists. So I would recommend, and as I was like trying to notice, we only have the cardiology resident, but of course, if you talk to your cardiology consultant, all of them will say, okay, we want to do PAD work, but you just have to identify just one champion who can, who's very passionate about it. That way you will have access to their inventory as well. If you have a problem finding wires and balloons, right? Because they will always have that access to it. And ICBD again is challenging in Pakistan, is in the sense we do some numbers, but not, as common as in the US. And the price is always the issue, especially people care more about their heart and their leg. Even if they have claudication and they can live with that, or they learn to live with that. So there are certain challenges involved, but again, forming that team with cardiology in the center, even at a place like AKU, you might get access to certain wires and balloons, just having that relationship with them.
Yeah, your thoughts are very much with Dr. Shahab. who think that super specialization or specialization is the way forward, and he does not want a peripheral intervention.
So that's the thing, when I say, just like we have a heart team approach nowadays, CT surgeons, cardiologists are finally getting along very well because of TAVR, structural heart. We should have a vascular team approach. And a lot of time in Pakistan, we get into this egos that, okay, I'm not going to ask for help and I'm not going to refer this patient. At the end of the day, we do what we do because of the patient. So we should always do what is best for the patient and try to work in a sandbox as a team. So it's very, very important.
For the sake of time, we can discuss during refreshment. And may I ask Dr. Sufi to give a token of appreciation to Dr. Sohail for his wonderful talk and for his precious time to come.
Thank you.
And thank you for all the participants on the Zoom. As we have got your texts and comments. Thank you for participating. Thank you everyone for coming and participating in this activity.